Neuroimaging for those who hate neuroimaging. Well, I tried to make the presentation as simple as I could. I hope you enjoy it. If you do, please consider subscribing to my channel. Today I'm going to talk about the foundation you need to have as a clinician to interpret neuroimaging. We will discuss all the modalities listed on this slide. Let's begin by discussing CT scan. CT scan uses X-rays to generate images, which means that the patient is exposed to the radiation while undergoing the scan, in contrast to the MRI. The first concept that you should understand is the density. The denser the tissue, brighter it appears on CT scans. You can imagine a scale of density where the density of air is located on the far left and the density of bone on the far right. CT is viewed either in the brain or bone window, depending which structure we need to inspect. Now let's discuss common causes of hyperdensity on brain CT scans. So the question asks, what appears white on CT scan? First thing that you should think of is a hemorrhage. Intraparenchymal or intraventricular, epidural, subdural, or subarachnoid. You can pause the video to appreciate the hyperdensities on these images. Another common cause of hyperdensities are calcifications. Calcifications aren't abnormal all the time though. Some pathological causes include tumors and infections, neurocysticercosis being a useful example. On the other hand, it can be a normal finding, particularly if it's located in choroid plexus, falx cerebri, pineal gland, or basal ganglia in elderly. Besides hemorrhage and calcifications, hypercellular tumors like lymphomas, or some other conditions like atherosclerotic arteries, contrast-enhancing lesions, thrombosed vessels can as well appear as white. Again, remember that it's all about the density of these conditions that contribute to their appearance. Okay, we have hyperdensities nailed down. Before moving to the causes of hypodensities, discovering what appears dark, please take some time to appreciate some other patterns of hyperdensities on CT scan. Any lesion that can cause pathogenic local edema to the brain can appear as hypodense or dark. Aged injuries of the brain, like an old stroke, being the other cause of it. Ischemic stroke, which is the most common type, is expected to have a distinct borders because it respects vascular territories. If the hypodensity is located on the cortex, like shown in the image, that's also likely to be due to ischemic stroke rather something else. Okay, now you know the basics of CT scan. Let's move to discuss the MRI business. We are going to cover all of the below listed sequences. T1 weighted MRI imaging is the most basic imaging used to assess brain anatomy. Pay close attention to the colors on this particular view, because everything else can be well inferred from knowing this sequence. On T1, gray matter looks gray, white matter looks white. So it is very easy to remember. What you need to notice is that CSF and the pathology of the brain appear dark, except when you use contrast, where the pathology appears white. In fact, T1 is the view used mainly for contrast studies. Now, moving on to the T2 weighted MRI imaging. This is the complete opposite of T1. So if you know T1, you can work out the colors of T2 and then eventually with enough practice you will decode it with your code spinal cord. Okay, what FLAIR stands for is Fluid Attenuated Inversion Recovery. To recognize this sequence, all you need to know is that it is similar to T2 and what A stands for in the name, which will help you to remember that CSF is attenuated or dark. Okay, what is the purpose of using FLAIR imaging if it is so similar to T2? Since on T2 the pathology and CSF appear white, you can't really tell where the lesion ends and the ventricles begin, if the lesion is located in a close proximity to the ventricles. So if the CSF was black, you would be able to spot the boundaries of the lesion, and that's exactly why we use FLAIR imaging in the first place. Okay, now let's do a little quiz. Can you tell the difference between these sequences? Feel free to pause the video and work them out. First, what you have to do is to spot which is T1 weighted imaging, because it is easiest one to remember, because their gray is gray, white is white, and CSF and the pathology of the brain appear dark, except when you use contrast. So you can infer T2 from T1. Having said that, and lastly, you know that FLAIR looks like T2, except fluid is attenuated, meaning it is dark. I hope you are still listening and watching. If you do, thank you. Now I'd like to talk about diffusion-weighted imaging and ADC. Both of these sequences are all about water diffusion. Brain anatomy is less defined on the sequences in comparison to T1 and T2, and the skull is not at all visible on DWI. Those areas of brain where water diffusion through the tissues is limited would be referred as diffusion-restricted areas. They appear white on DWI and dark on ADC. You can add a letter D to ADC and remember the color as dead, and DWI would be just opposite. The sequences are most commonly used in the evaluation of acute ischemic stroke because they can pick up changes even within minutes, which is much earlier than any other MRI sequences. How about SWI and GRE? It is worth knowing that SWI is newer version of GRE, which has better resolution, but it is slower to perform. They both are used to evaluate microhemorrhages and calcified lesions. Recall that hemorrhages and calcified lesions can also be picked up by CT scan, and we call it hyperdensities when they do. But these sequences of MRI are used to pick up more subtle lesions, which would be difficult to visualize on CT scans. MR spectroscopy is very interesting because it combines brain chemistry and neuroimaging. So you need to be aware of two metabolites, which are N-acetyl aspartate and choline. The measured quantities of NAA should always be higher than choline should the neurons be considered healthy. If NAA gets decreased, some sort of neuron disease must be suspected. Choline is a marker of membrane turnover, so if the quantity of choline gets increased, that can be telling of neuronal membrane damage. On image, you see a spectrogram of certain brain area. Normal pattern is characterized by having a 45-degree angle between the quantity of choline and NAA, which we call Hunter's angle. I know these sequences are very tricky to understand, but you are almost there. So now let's discuss contrast-enhanced MR brain imaging in a little bit more details. We have already briefly touched this topic when we discussed T1 weighted sequence. MRI uses gadolinium contrast in contrast to CT scan, which is performed with iodinated contrast. If there is any difference in color between pre and post contrast images, that means that disruption of blood-brain barrier have taken place and contrast leaked out. You should always obtain images before contrast administration so you can compare. Otherwise, if you don't know the baseline intensities of the region, you can't really tell if you're looking at hyperintensities. In terms of how we use it, contrast-enhanced MRI imaging is used to assess meningeal enhancements, which can be leptomeningeal or pachymeningeal. Leptomeningeal enhancements are present in infectious meningitis and malignant disease, and pachymeningeal in case of inflammatory conditions and intracranial hypotension. These are some examples of such enhancements. Notice little white tracks which involve deep brain structures versus only peripheries in case of pachymeningeal enhancement. Infectious and malignant conditions spread, so you can remember spread from surface to the deep layers of brain in case of leptomeningeal enhancement. If you're still there listening, I'm proud of you. Now, vascular imaging is used to assess vessels of the brain and neck. All of the listed modalities can be used for that particular purpose. CT and MRI angiography uses contrast in most cases to assess different pathologies of the brain. If contrast administration is contraindicated, different modalities can be tried. CT and MRI angiography uses contrast in most cases to assess different pathologies of the brain. If contrast administration is contraindicated, different sequences or modalities can be tried, like Doppler ultrasound to assess carotid artery stenosis. Just take some time to appreciate how different sequences look like. Transcranial Doppler is used to assess proximal intracranial arteries, especially in case of arterial vasospasm after aneurysmal subarachnoid hemorrhage. And the last one, 2 sequences of nuclear imaging. We inject radioactive substances to evaluate brain metabolism and brain blood flow, mainly in case of neurodegenerative disorders such as Alzheimer's. Areas with decreased glucose uptake or metabolism, which is the case in Alzheimer's, show decreased uptake of contrast and thus emanate low signal on imaging. Thanks for watching. If you like this video and want more, please consider sharing this video to your friends and subscribing to my channel.